It's a great pleasure to introduce my co-chair, who's been doing an amazing job so far today, Martin Hewison. Martin's from University of Birmingham, and we're going to move away from fatty acids and lipid mediators into fat-soluble vitamins now. And Martin is a real expert on vitamin D and immunity. So over to you, Martin. Thank you.
Thanks for that kind introduction, Phil, and thanks to the program organizers for inviting me to speak at this really outstanding meeting today. It's been really exciting. My talk today is about vitamin D, immunity, and COVID-19. I think, as several of the speakers have pointed out, this has been very much in the public eye over the last year, and there's a lot of stuff out there, and it really is too much for me to cover in one 20-minute talk. Instead, what I'd like to do is to focus on some things that I think have been lost in the general debate about vitamin D and human health, and that is sort of, how does it work? Why are we interested in vitamin D and immune function? How does it work with the immune system? Why has that then been linked to COVID-19? And I'll also like to just make a case at the end that we might have to revise our view of vitamin D for future studies. So vitamin D is interesting. Of course, this is a sort of nutritional session, but in reality, we're going to get most of our vitamin D from the action of sunlight on our skin. About 90% of all our vitamin D arises from the action of sunlight on 7-dehydrocholesterol to create vitamin D3. You can get some vitamin D from foodstuffs, from fortified products, for example, in North America, and fatty fish. Some countries eat a lot of mackerel and herring, and that has quite a lot of vitamin D. And there's vitamin D2 present in some plants and mushrooms. Whatever your source of vitamin D, you have to undergo then 2 metabolic steps to get the active form of vitamin D. First, in the liver to produce 25-hydroxyvitamin D, and this is the major circulating form of vitamin D. This is the form we refer to when we say somebody's vitamin D deficient or supplemented. It's this 25D form, but it's not the active form of vitamin D. The active form of vitamin D is 1,25-dihydroxyvitamin D, which is produced primarily in the kidneys by the enzyme CYP27B1. And it's this form of vitamin D that drives the endocrine actions of vitamin D. These are the ones we associate with skeletal homeostasis. And it's principally acting on the nuclear vitamin D receptor in target tissues such as the GI tract to improve calcium homeostasis and strengthen mineralization of bone. So this is a very much an endocrine action. It's controlled by other hormones like PTH and FGF23. But in the last 20 years or so, there's become big interest in another arm of vitamin D physiology, which is for other tissues, shown here as the lungs, the spleen representing the immune system, and placenta, for example, which also express the nuclear vitamin D receptor, so they can respond to 125D. But these tissues have also been shown to express the vitamin D activating enzyme CYP27B1. So they can actually produce 125D locally if the 25D precursor molecule is delivered to them. So this is more of an intracrine mode of action. And this is the one that's really been tagged to effects such as antimicrobial, anti-inflammatory, and anti-cancer effects of vitamin D. And it's an interesting difference between this and the endocrine action of vitamin D, because this action of vitamin D is thought to be more dependent upon the availability of 25D, in other words, your vitamin D status. So if I'm vitamin D deficient, it may be that these effects are less effective. And conversely, if I'm vitamin D supplemented, the idea is these antimicrobial, anti-inflammatory, anti-cancer effects will be better promoted. And this is best represented really by the immune system, where pretty much all the cells of the immune system are known to express the vitamin D receptor, VDR. And we've already seen a nice version of this picture from Phil's initial talk. But within the innate immune system, cells such as macrophages and dendritic cells also express this vitamin D activating enzyme. So they can take the precursor form of vitamin D, activate it locally. That can then have effects within these cells that are intracrine. But it also means that 125D can be released for potential paracrine effects. So this could be effects on neutrophils, which also express the vitamin D receptor but don't have CYP27B1, and also on cells from the adaptive immune system. So the best example of this intracrine action stems from work that I carried out alongside Robert Modlin and John Adams when I was working at UCLA. where we're interested in how vitamin D metabolism and function changes when cells encounter pathogens. In this case, we were interested in how macrophages and monocytes use vitamin D when they encounter the Mycobacterium tuberculosis. Of course, we know that these cells can phagocytose the mycobacterium, but if left unchecked, the mycobacterium can multiply within the cells, go on to kill these cells and infect other cells. We know these cells also sense the pathogen through pattern recognition receptors, such as the toll-like receptor system. And two of the key genes that are activated when macrophages encounter tuberculosis is the vitamin D activating enzyme CYP27B1 and the vitamin D receptor. So this led us to suggest that if these cells then take up precursor vitamin D, 25D, convert it locally to 125D, that can then interact with the vitamin D receptor and then drive transcriptional responses. We were particularly interested in the ability of vitamin D to increase transcription of an antibacterial protein called cathelicidin, or LL37, which gets incorporated into the phagosome to basically punch holes in the cell walls of bacteria and kill them. So this was a very simple model, but it's one that really caught on. And the idea was simply this, that if you increase vitamin D supplementation, increase 25D levels, and drive increased bacterial killing. And really the simple intracrine model is now the backbone of almost all of the extra-renal, extraskeletal effects of vitamin D. This idea that simple vitamin D supplementation can lead to a strong biological output. Of course, it's not quite as simple as that. Since then, we've gone on to show that other antibacterial proteins are also promoted via this intracrine transcriptional model. We know that vitamin D also very potently promotes autophagy within these cells, so it can enhance the environment in which bacterial killing can take place. We also know that vitamin D suppresses hepcidin, which is an iron regulatory protein in immune cells. It basically acts to promote the removal of intracellular iron from immune cells, because iron is a very potent foodstuff for intracellular bacteria. So if you get accumulation of iron within cells, that can also enhance the inflammatory response. So vitamin D suppresses iron homeostasis as well. This is an antimicrobial, antibacterial mechanism, but we know that some of those mechanisms can also be applied to antiviral responses to vitamin D. So there's virus uptake via endocytosis, and again, if the virus is allowed to replicate, it can then be released from the cells and go on to cause greater infection. But we also know that viruses are sensed by the same toll-like receptor system that we saw for TB. Probably this involves intracellular toll-like receptors for viruses, but the net effect is the same. You know, we get induction of the vitamin D activating enzyme, vitamin D receptor, and then promotion of these similar responses that we saw for bacteria to promote antiviral responses. And in this case, for example, even antibacterial proteins such as DEF-B4 and cathelicidin can also promote antiviral responses. Again, the overall effect is that vitamin D supplementation will lead to increased viral clearance. So that's cells within the innate immune system, but as I've already pointed out, vitamin D receptors also found within cells from the adaptive immune system, the T cells and B cells, for example. And so we can propose this model here in which our innate immune cell, in this case a dendritic cell, antigen presenting cell, interacting with T cells to promote T cell proliferation and an adaptive immune response. What we see here is that this intracrine model with physiological levels of vitamin D, 25D, being able to be converted into 125D locally within the dendritic cell. This may have intracrine effects in terms of modulating the T cell receptor interaction with T cells. That's certainly possible. But we also know there may be release of 125D into the immune microenvironment to produce paracrine effects. And because the activated T cells express vitamin D receptors, they can respond to 125D as well. And the overall effect here is that 125D promotes an anti-inflammatory effect, suppressing Th1 and Th17 cells, whilst at the same time promoting tolerogenic pro-regulatory effects through Tregs, T regulatory cells. So there's this sort of double effect, double whammy of vitamin D being anti-inflammatory and pro-regulatory. So overall, if we look at the effects of vitamin D in the context of infection, we can say that it promotes a double-edged sword. In this case, instead of having the double-edged sword being one bad side and one good side, really there are two good sides to vitamin D, in that it promotes protection against infection, whilst also limiting the overexuberant inflammation that can occur as a response to infection. Of course, we know that this is particularly important in the context of triggering autoimmune diseases, but as we'll see later on, it's also important in the context of diseases such as COVID-19. So you'd like to think that there's these sort of mechanistic sides of vitamin D were driving an interest in vitamin D and immune function, but in reality, we have to be honest and say that really what has driven the public interest in the potential role of vitamin D in human health has stemmed from association studies which have linked low vitamin D levels with increased risk of common human disorders. And of course, we know there's a long-standing link between vitamin D deficiency and diseases such as rickets and osteomalacia. But more recently, we've seen that low vitamin D has been linked to other diseases, infectious diseases, as I've already mentioned, such as TB, autoimmune disease, for example, and even in the setting of pregnancy, where a number of disorders such as miscarriage, preterm birth, and preeclampsia are all thought to have an immune basis. So here we've seen that low vitamin D is linked to a higher level of these disorders. But in the last couple of years, clearly what's been most interesting is that there's been this enhanced link between vitamin D deficiency and respiratory infections such as colds and influenza. And in the last year, COVID-19, so that I think at this moment in time, there have been something like 35 studies showing decreased levels of vitamin D are associated with increased risk of COVID-19. Again, these are association studies. So here, I guess we can say is that in the context of protection against COVID-19, here we're looking, so this is something which, as Phil has already mentioned, the idea that vitamin D is acting as a nutrient in a community health setting to diminish or limit the infection. But there's another side to this, of course, which is that the anti-inflammatory effects of vitamin D could be seen as more of a hospital-based effect, in which we can perceive vitamin D to be more of a drug. So in the setting of a nutrient population health setting, this is really where vitamin D has been most predominantly studied. This is actually a study going back to 2017 looking at the effects of vitamin D on supplementation on acute respiratory tract infection. This is a systematic review in which Adrian Martineau at the time used 20 studies to show that vitamin D supplementation did indeed lower the risk of infections with colds and flu. Now, this has been updated in the last few months to include, it's almost, well, more than double the number of studies that are being included in the meta-analysis. Again, the significant effect is still seen. It's a small effect of vitamin D, but vitamin D supplementation does appear to diminish the risk of respiratory infections such as colds and flu. What we need to know really now is whether the same applies to COVID-19, and that there are 4 large studies that are ongoing at the minute, and which will come to fruition in the next few months. But we can postulate that vitamin D could be applied to this very nice model that was proposed by Ian Mackay, the Australian virologist, this idea of the Swiss cheese model for protection against respiratory viruses. And the idea is, we have our individual over here who's protected by various layers of Swiss cheese from the virus on the far left, with social distancing and masks being over here, and vaccines, of course, being the ultimate shared responsibility that we have on the far right. Of course, each of these individual interventions are not perfect on their own to protect against the virus, but collectively they provide a good level of protection against the virus. And here we'd like to suggest that vitamin D supplementation could be added as an additional layer of Swiss cheese to the far left of this schematic. So that's vitamin D in the setting of nutrients as a nutrient. What about hospitalized patients? Has been less studied in this context, and there's a good reason for this, which is that in order for vitamin D to be effective in this hospitalization setting, that you've either got to use very high doses, bolus dose supplementation of vitamin D, and this comes with its own set of problems in that high bolus doses of vitamin D are known to trigger feedback control mechanisms that might actually limit its efficacy. So a way to try and get around this is to use other forms of vitamin D. And there's been at least one study that has used calcifidiol. This is actually 25-hydroxy-vitamin D itself. So this sort of cuts out the middleman and circumvents the need for conversion of vitamin D to 25D. And the whole idea here is that using a high dose of this may be more effective at suppressing inflammation. But again, this is in a setting as using vitamin D as a drug. And why might we think that? Well, this is a rather busy picture, but I like it. This is one generated by my colleagues at the University of Birmingham. And it shows the various stages of coronavirus infection through the ACE2 receptor, going to viral replication, triggering of the innate immune responses, complement activation, all those innate immune cells that I mentioned earlier on, macrophages and neutrophils, triggering of the adaptive immune response through T cells and so on. But ultimately, if this doesn't work, we have this over-exuberant inflammation leading to decreased permeability of barrier sites like the lung epithelial cells and endothelial cells, which can then trigger off acute respiratory distress syndrome. And what we can see here are the various drugs that have been proposed to interact with different stages of the viral function and the different trials that are ongoing. We can see that vitamin D could actually be applied to several of these points. So it isn't beyond the reason of, it's quite plausible to use vitamin D in the setting of this, this viral transmission model, with vitamin D being used as a drug rather than a nutrient. But at the moment, there are relatively few studies that are looking at that, and these are really coming to fruition over the next few months. So what's my sort of final take on all this? The questions I've asked here on my sort of final slides are, do we need more trials? There have been so many trials for vitamin D, and I'd say probably we do need more trials, but in order to carry out these trials, really, we need to better organize these trials. At the moment, too many trials have been done rather in a rush. I suspect they're very expensive trials, but they've often really not effectively used vitamin D in the way that we know that it can be used in the context of its biological function, its mechanisms. I think the key question that we still have to answer before we do really any more trials is, what is the optimal level of vitamin D that's needed to improve immune function, to give good immune health? We just don't know that. We know that if you want to avoid rickets, then if you get above 25 nanomolar serum 25D, that will work. But for other biological responses to vitamin D, we don't know what the optimal level is. And as a sort of final point, I'd like to make a case for maybe we're using the wrong form of vitamin D whenever we look at vitamin D and human health. If you look at all of these effects, antimicrobial, anti-inflammatory, anti-cancer, we look at all of these in the context of one vitamin D metabolite, 25-hydroxyvitamin D. There's a good reason for this. It's easy to measure, it's cheap to measure, very convenient, but it's an inactive form of vitamin D. It's carried around in the circulation bound to vitamin D binding protein, which could have a significant effect in impairing access of 25D to target cells. Certainly within the immune system, it would appear that actually not total vitamin D, but free 25D, the bit that's not bound to DBP, is the part of vitamin D that accesses immune cells and produces immunomodulatory effects. And DBP itself has its own immunomodulatory function, so it has an independent effect of vitamin D. On top of all this, of course, it's not the active form of vitamin D. 125D is the active form of vitamin D. And although I mentioned that the intracrine model is the one we're working towards, there may be other cells, neutrophils, eosinophils, for example, which actually respond to circulating levels of 125D. The problem here is that it's more expensive and more difficult to measure. Then finally, I'd like to point out that in common with all the other steroid hormone systems, vitamin D has multiple other metabolites that can have a big impact on how it achieves biological functions. We know, for example, that there are multiple catabolites of vitamin D via the enzyme CYP24A1 that are important. The higher the levels you have these catabolites, the more catabolic your response to vitamin D may be. So we're increasingly seeing these ratios of 24, 25, and 25D being used to monitor biological function to vitamin D. If we just take a vitamin D through sunlight or foodstuffs, before it ever hits the liver and gets 25-hydroxylate, it can be converted via the side chain cleavage enzyme, CYP11A1, into different forms of vitamin D. 20-hydroxyvitamin D has been shown to be a potent anti-inflammatory agent on its own. And it could well be that this form of vitamin D is triggered through some of the oral supplementation routes that we've seen in many of the trials. And finally, in common with all of the other steroid hormones, again, there are large reservoirs of vitamin D in the circulation that are present in conjugated forms, glucuronide and sulfate forms. There's as much 25D sulfate in circulation as there is 25D. And it's quite possible that in some cells, having specific sulfatases may help to utilize vitamin D from this particular reservoir. So I guess my point would be here is that over the last few years, we've really tried to simplify vitamin D to fit in with many trials, when in reality, I think it's quite a complex system. And I think we need to go back to some very basics of vitamin D biology to understand many of the trials that have been carried out recently. On that note, I will finish, except to thank my various collaborators and funders for all their help over the years. And thank you for your attention.
Okay, thanks very much, Martin. That was really, really superb overview of not just the immunology of vitamin D, but some of the other more nutritional and physiological aspects. And I learned some new things about vitamin D, so that was brilliant. I'm going to ask you the question you asked of Bill, and I think you maybe asked me something similar, which is, I mean, as you say, there are dozens of studies associating low vitamin D status with COVID-19 infection, severity, mortality, you name it. But does infection impact markedly on vitamin D status?
I think it does. I mean, I think we have to be honest and say that, yes, I mean, vitamin D can be an acute phase reactant. Mm-hmm. The vitamin D binding protein, for example, is known to be lost in large amounts if you're in acute care. So that will take a lot of vitamin D with it. So I think it's quite plausible that in some settings, vitamin D levels will be lowered as a result of inflammatory disease. I think we're going to see more studies come through that have circumvented that, and that although there may be association studies, you know, depending on when you do the vitamin D analysis, you may have already circumvented the acute phase suppression of vitamin D. Yeah. This happen. I think obviously that's why we need to have supplementation studies.
Yeah, yeah. I mean, there are a few trials where I think quite high dose vitamin D has been given to hospitalized patients that suggest some benefit. But I think the way some of those trials are done maybe is a little bit suboptimal. I don't know if you want to comment on that.
Yeah, I think it's important because I sort of skipped over that in my slides because I wanted to try and keep to time. And I think Williams just pointed that out. There was a very big study came out in JAMA from Brazil, I think, which showed they used very high dose of vitamin D, 200 international units, but it was given to patients like 7 days after they got into hospital. And they were looking for effects 7 days beyond that. I just could never see how this was going to work. This was a trial that was designed to fail because you would trigger so many feedback control mechanisms before you'd ever had a chance to achieve any benefits. It just was never going to work. And so the way people are trying to get around that is by a study, which is also, it was published as a preprint and then taken down, which they used 25 hydroxyvitamin D calcifidiol. This will get your vitamin D levels up much quicker and could be used in an acute setting. And that trial did have some very positive effects, but there was some question about how they had randomized the patient. So that one, as I believe that is now back out and is with a journal at the moment, has been revamped, but with the same effect. Yeah. I understand why that was done. That would, to my mind, that is a better design study because it used the form of vitamin D. It's more likely to work in an acute setting.
Yeah, I think your comments allude to some of the things that Adam said about the omega-3 trials, that in this setting, it's actually really hard to do decent randomized controlled trials because so much else is going on. And I think, you know, I've talked a bit about vitamin D myself, so I've looked at the studies and, you know, what looks like it might be a randomized controlled trial is actually just a trial where some people happen to be given some vitamin D and some other people didn't. And, you know, they're not well matched for all sorts of things. So it's really problematic trying to do decent trials at the moment, I think.
Yeah, I think, and there aren't actually that many in terms of sort of protection against infection. There aren't that many trials. I think there's 4 worldwide, and one of those is in the UK is Adrian Martineau.
Yes,
he's running that. That's one of the bigger ones. You know, he said that it's problematic because they started it in November, but by the time they got around to January, February, everybody was getting the vaccine. Yeah. So but he raised an interesting point, which is that they're now interested in whether these sort of supplements, and that could apply to omegas as well, is, you know, are they improving vaccine efficacy? Is there a
Yeah.
better, so they're now doing a sort of overlaid study. It makes it slightly more complex, but it will be interesting to see whether, your immune health, which we're pushing as an idea of improving general protection against infection, could actually also benefit if you're vaccinated or you're about to be vaccinated, so.
Yeah. I wrote a letter which is available to British Journal of Nutrition on this point, that when people are thinking about the immune system, vaccination response requires a decent immune system. So all the things we're thinking about could actually be relevant to vaccination.
Indeed, yeah.
But again, at least in the UK, the vaccination sort of came on with steam, so it wouldn't be possible to do trials around vaccination very easily.
No, but I think that in this case, this one vitamin D trial may overlap just sufficiently to be able to get something interesting out of it. Well, it'll be intriguing anyway. So.
Yeah, great. I think, again, in the interest of time, we need to wrap up. Martin, thank you.